Coming to you from ACOG's annual scientific meeting in San Francisco, I'm Dr. Matt Birnholz for ReachMD. I'm joined by Dr. Mark S. DeFrancesco. He's the president-elect of the American College of Obstetricians and Gynecologists. Dr. DeFrancesco, welcome to the program.
Thank you. It's great to be here.
It's good to have you. So you are just about to come in. When we say president-elect, we're talking within a matter of hours you're going to be the president.
Tomorrow morning, 24 hours.
24 hours.
Yes, sir.
Tell me a little bit about yourself before we move in on some of your the initiatives and your vision for ACOG.
Sure. I'm in general OBGYN practice. I've been in private practice for 31 years in Waterbury, Connecticut. After about 18 years of combined OB and GYN practice, I started to also look into the practice management world. I went back to school on a part-time basis and got an MBA and started developing a large group practice in Connecticut, which then led me to reducing my clinical work to essentially office GYN only for these last 10 years or so, and also added to that a lot of administrative work. So I was Chief Medical Officer for Women's Health Connecticut, which included 200 OBGYNs in Connecticut, largest single specialty group practice at that time in the country, devoted to women's health care. And it got me very interested in practice management. So my forte, if you will, is practice management, what's going on in healthcare policy, et cetera. And at the same time, I still see patients in my office because, again, that's the last thing I want to give up. I love taking care of patients.
Was that part of the game plan when you moved in on the MBA, or was that something you didn't necessarily expect, getting so heavily entrenched in the practice management side?
Absolutely. Great question. Actually, between college and medical school, I worked in a bank for 3 years, so I actually had a little business background. Felt I wasn't doing enough for society, so I went back to school to become a doctor. And after about 15 years of medicine, felt that I really needed some business education because of what was going on in the healthcare industry, consolidation of payers, and just a lot of infringement into medical decision making by policymakers and by payers and whatnot. So I said, you know what, I really need some more formal educational training. And one thing kind of leads to another, and before you know it, because of that educational background and getting the MBA, kind of resurging my interest in the business side of things, I realized that I could also contribute to the specialty by helping our practices survive. So really helping to keep our practices whole and intact and all that with some of the business experience I had. But again, I never wanted to walk away from the clinical side of things because that's so important to me.
Of course. And did that requisite experience, in addition to your clinical background with practice management, sort of put you on the path towards leadership roles in ACOG, or was that always in the cards? That was always in the cards, too, because from when I was board certified in the mid-'80s, I became department chair in my community hospital that I was practicing in. And as department chair, got involved with the ACOG local section in Connecticut. And after several years, rose to the chairmanship of that Connecticut section, and then from there parlayed that into a district chair for the larger New England district, and then from that into a national office at the secretarial level. Unrelated to the MBA, unrelated to the business world, I think that was really believing in organized medicine in the way that ACOG practiced it, at least, that we were doing things for our patients, and really we were a fantastic organization. 93% of OBGYNs who can be in ACOG are in ACOG. We have one of the highest participation rates of all the professional societies, and that's you don't need an MBA to be president of ACOG. Let me put it that way. So. Well, it's not going to come to any surprise to anyone that you'd move in to this role. You do have a strong demonstrated track of leadership at ACOG. But now that you're moving in, and as we said, starting tomorrow, get going.
Right, exactly.
Air Force One will fly you all over the place.
That'd be nice.
What's on the game plan for you? What's the vision that you want to bring into ACOG this year?
Sure. My vision is actually threefold. I want to do something for our patients, something for our specialty, and something for ACOG, for our organization. My predecessors, Dr. Conry and Dr. Jennings, the last two presidents, have started us on the path of looking at women's health generally. So Jeannie Conry 2 years ago developed a women's care task force, and it kind of helped to define what should be done in a well woman visit and how we should be taking care of our patients. Dr. Jennings recognized, because of some of the changes brought about by the Affordable Care Act, et cetera, hopefully there will be a lot more people covered and who will be seeking our care. And we need to be more efficient in how we deliver that care. So we need to work in teams and have collaborative providers work with us and kind of re-engineer how we do practice. And I'm taking those two platforms or planks in the platform to start with, and trying to expand that now and say, okay, let's really focus on something that we can make a great positive impact on in terms of population health, and looking at particularly obesity and smoking. These are very hard things to address, but I think they're out of control. Certainly obesity is out of control in this country, smoking making a little bit of a dent. But 780,000 people per year in this country die from obesity and smoking effects versus 70,000 every year who die from breast, ovarian, uterine, or cervical cancer. So in part that's because we do such a great job in the GYN side of things, and we're helping to seek and destroy, early cancers on the GYN side. But we're not doing a lot to stop people from getting obese and stop smoking. So we could keep doing what we're doing on the GYN side, but add to that some more comprehensive approach to our patients. And if we can make a dent there, we could really do a lot more than we're doing already, anyhow. And I think we could help.
It's really interesting that you mentioned the obesity epidemic and the potential role that ACOG can play, and the initiatives that you can roll out there. Dr. Conry had spoken about the traditional reticence that there's been, not just among the OBGYNs, but among many specialists worldwide when it comes to approaching obesity.
Sure.
How do you envision being able to tackle such a big problem? And no pun intended in that, but how do you envision moving forward with that and actually creating meaningful applicative interventions?
Sure, yeah. I think we have to first broach the subject. I think it used to be taboo, certainly not so much smoking, because I think people are more comfortable telling patients not to smoke. But obesity, especially if you're very thin and very trim, and it's easy for you to say, to tell other people to lose weight. I'm blessed, I guess, with a little bit of extra weight, so I could start this conversation by saying, you know what, we both need to lose some weight this year, and point it out to people. But you can't just tell somebody, even in a joking fashion, we need to lose some weight and then see you next year for your next visit. So I think we have to kind of develop an ongoing program for our practices where we get a patient who's interested in it, we get them some dietary advice, we put them on a schedule of every once a month you come back just to get weighed, almost like a Weight Watchers, or we outsource it to Weight Watchers. And I don't mean to use that particular commercial brand, but anybody who can provide weight services, in other words, in our neighborhoods or whatever. So we need to be tied in. We need a care coordinator in the office. That's why we need a team, to figure out what resources are in the area of our practice that we can refer a patient to. And if all else fails, you bring them back to the office so they know they're going to be weighed in once a month. So they know that you put them on a schedule. So a patient who's really engaged understands that you really are serious about doing this. Now, that also means changing the healthcare system. That means making sure that the insurers are willing to pay for that. I would think that they would rather have patients losing weight and being healthier downstream, and therefore it would be worth their while to pay a small E&M code for that visit or whatever. But if not, it almost doesn't matter, because I think ultimately we're going to be paid for value, not for volume. I think ultimately the healthier we can get our patients to be, the more we're going to do well from that in terms of keeping our practices thriving and surviving and all that. So I think it behooves us to not worry about the payment up front and just get the patients in, intervene with our patients and kind of sell that story. But it changes the way we do things. And as you know, practices today are so overburdened with other regulatory things, with adoption of electronic medical records, with other things that really do interfere with the practice of medicine sometimes. That's why we really need to look at re-engineering a little bit how we practice. That's why a team is needed, and that's why I think more and more doctors are going to larger group practices where some of these resources are there. It's very hard to do that in a 1 or 2 doctor group. So as much as ACOG might be able to help by producing templates, toolkits, scripts to use when you talk with patients, I think those kind of things we can help with. But in the long run, the system has to change.
Right. I think you perfectly answered my follow-up question, which is going to be in the downstream versus upstream debate of where the most meaningful change can happen. It sounds like the organization is going to play a responsible role in trying to implement recommendations, but it also has to start at the practice level, and there has to be a support structure for the people in practice, especially in the smaller practices.
Exactly. So that's what we're doing for patients. If we have time, I'll tell you a little bit more about what we're going to try to do for the specialty.
Yeah, please do.
Which is looking at physician satisfaction, or dissatisfaction is a better word. Every year or so, Medscape comes out with a national study that does show, they survey 25 different specialties typically. And consistently, we come in 3rd or 4th from the bottom in terms of being satisfied. Not very good. A burnout survey just came out. We were second or third from the top. Anyhow, so very, very sad anyhow. But again, given all the constraints that all practices, not just OBGYNs, but certainly we take it on the chin from the medical liability point of view more than many other specialties. Then you've got just overall perception, at least, of loss of autonomy, loss of societal respect, and we're just becoming a commodity, and it's just different anyway. People are burned out and they're depressed anyhow. So I'm saying we take the triple aim of providing better care at lower costs and keeping our patients happier, and make it the triple aim plus one. And the plus one is physician satisfaction, because unhappy physicians can't provide good quality care. I think it's as simple as that. Their heart's not in it. They're not excited to go to work in the morning, and that's not a good thing. So what we're going to do is use our section and district leadership to kind of disseminate surveys, analyze, root cause analysis type of thing. Even though we kind of have an idea of what's causing a lot of this dissatisfaction, we'd like to document it and really say, these are the things. Okay, now what can we do something about, and what can we help with? So we're hoping there's a little bit of a Hawthorne effect, so that just studying it might help to improve it a little bit. At least people know we're trying to do something. But also maybe something will come out of this that will help us improve things, so that we can really restore some health to our practices, and then that will help us improve patient care.
It fascinates me that in a time in which burnout has been a crisis for many years now, that the root causes still aren't necessarily documented. I mean, that's what amazes me.
Yeah. Well, I think it's easy to assume it's decreased reimbursement, harder work, just not as much fun, as it used to be, and government regulations and administrative interference from insurance companies. But let's try to really get some numbers to prove that. I think something else may turn up that also may suggest a way to approach it. Even if we can't change some of the things, some of the causative factors, there may be other ways we can change our reaction to them, or deal with them in a different way. Again, with a team approach to healthcare, where let's design the system to absorb those shocks and take it off the doctor's back. I think, but that's why it's tough to do it when you're a solo physician.
Right.
You don't have the resources to do that. And then for ACOG, basically, we're going to take another look at our strategic planning. And about every 5 years or so, we try to revamp our strategic plan, at least review it, and time is up for us to do that. So we're going to kind of, again, look at, where does ACOG want to be in 2020? So we're going to basically call it ACOG 2020, and basically start looking at the strategic plan that's currently in place, see what is still relevant and what might need to be adjusted to get us to where we want to be in 2020.
And on the technology question, I had the opportunity to speak to some people who were assessing ACOG's adoption of social media, digital media. Gave them a good review. Said that it was a strong early adoption, that the younger membership is coming on board because of that.
They drive it, yes.
Do you envision that being part of the strategic plan?
Yes, absolutely. Because I think better apps, for instance, we've got a basic one now, but we need to improve that. We need more apps that the public wants to use also, not just our members, and podcasts and just other ways to reach people in digestible bits rather than a 2-hour-long lecture on a webinar or something like that. So I think we'll definitely be changing that. Our young members are really helping us drive that, and definitely some change in some of our leadership over the past couple of years has also helped to really promote that.
And this is a tenuous period in the political landscape of healthcare.
Yes.
Do you envision the strategic plan becoming fluid to those potential changes that might come along?
Sure. I think that's part of it. I think it has to be a living document in a sense, and anything living has to be amendable on the fly, basically, to account for things that change. So we can't be, this day especially, this day and age, we cannot take the typical, we'll wait till the next board meeting to deal with this, or we'll have another planning session or whatever. We have to have a team in place that can just, on the one hand, you don't want to keep going left and right and left and right, left and right, but on the other hand, you want to be able to respond appropriately. Better if we can be proactive and anticipate change, but at the very least, we should be able to react to unexpected change and turn it on a dime if we need to stay fluid. Absolutely.
It seems like a great closing thought, but is there anything else that you want to add for our audience that I might not have asked you that you'd like to put out there for our particular healthcare professional audience?
Just come to D.C. next year when we're doing our 2016 meeting at the close of my year, and you could hear about how we did. But we'd love to see you in Washington next year.
Oh, we'll be happy. We'll definitely be there.
Great. Thanks, Matt. Appreciate
Well, with that, I very much want to thank Dr. DeFrancesco, President-elect of the American College of Obstetricians and Gynecologists. Again, thanks so much for your time, Dr. DeFrancesco.
Thanks, Ben. Appreciate it.
If you've missed any part of this episode, or if you want to check out other episodes on ReachMD, visit reachmd.com. And thanks as always for listening.